So let's talk about structural racism and cardiovascular health. Definitely a harrowing topic to talk about all of this sort of stuff. But I think just understanding how the structures that we have in this society and then in global societies really relate to health outcomes. The first thing we'll talk about is really what is race? What is race? What is ethnicity? What are these things? And how, again, do they relate to cardiovascular outcomes? So race, as we know, race is a social construct, right, that looks at artificial things like hair, skin color, physical characteristics, and really puts people into groups. And we know this is a social construct, but I think the most important and fascinating thing about race and the construct of race is that it really depends on the social needs of the time, the economic needs of the time, the political needs of the time, and that's how people are either grouped into one category versus the other category. And it's not based on genetics or anything else. It's really the needs of a society, of a community, of a nation at a particular point in time. That's really what decides what race is. If you take, for example, just looking at these particular slides, and my aunt and when I have family in London, and when they immigrated from South America, they saw these signs: no Irish, no blacks, no dogs. And so to think about those were the groups in the United Kingdom who were excluded. It's really, I think, odd if you look at it to put blacks and Irish and then also dogs, and just thinking about how people viewed races and different types of people. I think really importantly, just looking at how we define race based on the needs of the time. Italians in the late 1800s and early 1900s weren't considered white. They were considered less white, particularly Sicilians. And when they immigrated to the United States, they fraternized with black people in the South. They worked in those places, and guess what? They got lynched and mobs killed them with black people. And if you go back to those times and just listen to all of the reports about Italians and Sicilians talking about they're a different race of people, that they quote unquote deserve to be killed. And this is how the economic and political needs of the time really put Italians with black people as one race that should be killed. It wasn't until the Italian government in the late 1800s cut off diplomatic ties with the United States, where there was an active effort to move Italians from being killed with black people in the South, and they actually moved this to Congress to look at protecting foreign nationals. And Columbus Day is also sort of tied into this whole narrative and really moved Italians from being lynched. And the same thing, you could think about different populations, and Irish as well has gone through similar struggles. And so who is white and who is other, this changes over time, and it's really dependent on the needs of the population. Again, nothing genetic, nothing biologic, it's just really social needs. And then we look at ethnicity. And so ethnicity is sort of the same social construct, but just using language and geography to sort of group people together. And when you're looking at ethnicity, those also can be confusing sometimes. And so I put together a list of common races and ethnicities, and these are for America. What we tend to think of in terms of race are usually white, black, Asian, Native American, Pacific Islander, Native Hawaiian, and then ethnicities are more Hispanic, Korean, Haitian, Navajo, Cuban. And I think it's important to understand in this construct that you can mix and match from race and ethnicity, right? And I think that's sometimes something that people always forget, that you could be a white Hispanic or a black Hispanic or an Asian Hispanic, or you can be, a white Cuban or a white Haitian. And so these are sort of ways that we organize race and ethnicity in this social construct. And I think sometimes it's confusing, and I think we have to think about it in terms of a worldview. What are the races and ethnicity in different countries, and how people look at these terms? And so based on all of that, then let's talk about racism, what happens when you have the social construct, and now we understand what race is and what ethnicity is, and look at the types of racism. So you'll see that we have personal, then we have interpersonal, and then we have institutional, and then also structural. And I'll save structural racism for last, but let's talk about personal racism. And that's your own personal racism that, can be internalized, where you think that you're better than another group of people, and those are your own personal, your private beliefs. So that's personal racism. Interpersonal is when you share them. When you share them, that I see you and I know that I'm better than you, and I'm going to tell you, or I'm not going to give you a job because I know that, you're not qualified because of your race, etc. And those are the two types of racism that we tend to think about when we think about racism. And we need to move beyond the interpersonal and personal racism to think more institutional. And so institutional racism is not just one person saying something. It's a whole entity. It's a banking system. It's another system that's actually leveraging negative outcomes. And when you think about this, we have some examples. Every sector of our society, there's an example of institutional racism. So if you think about housing, and this is showing that, when people are praised for houses, there was something on the news showing when a person was black and they had the house and appraisers came, it was appraised for $330,000. And then that same house just took out black people and then put in a white couple. That house was then appraised for $465,000. That's the bias that exists in the system. But imagine taking away $120,000 from someone just because of their race. And this is how it's entrenched in our system. There was another article that popped up in the New York Times looking at buying houses in Long Island, and realized that realtors and brokers would only show certain houses to certain people. And so this is not the Jim Crow South. This was 2019, 2020. And the same thing happening where people are not allowed to buy houses in certain districts. And if you think about all of the things, then you think about incarceration. If you look at the literature, you can see that Black and Hispanics for the same crimes are sentenced to more severe, more long prison sentences. You can see the arrest rates are increased. You can see education, which we talked about, and social determinants of health are disparate. The school systems are disparate. We know the hospital systems that serve those neighborhoods also are disparate. And so you can start to see what institutional racism is. And I think it's really important to look at that and realize that there's no one person who's pulling the lever for these institutional outcomes. It's into our society, it's buried, it's into our policies and into our practices. And I think we really need to understand that when we're talking about institutional racism and we'll talk about structural racism, we're not speaking about a specific person. We're talking about, again, policies, practices that affect people.
So Black and brown communities in this country experience significant health inequities, and this is because of adverse social determinants of health. Structural racism is probably the most important of these underlying structural determinants of health equity, and it is defined as laws, policies, and practices that were born out of a history of discrimination and are now embedded within cultural, economic, and societal norms. Add to an underlying political and economic context that hinders these communities' access to care. There's also lower socioeconomic status as defined as low educational attainment and subsequent occupational issues. The last of these is someone's neighborhood environment, which can contribute to their overall socioeconomic status. So this underlying abnormal political and economic context defined by these structural determinants of health, really they have intermediaries that further determine someone's health equity. These can be a local social or community context where food may be scarce, where there's other abnormal social cohesion and lack of support systems, other psychosocial factors. These contribute to someone's lived personal experience and how much implicit bias they experience, what sort of microaggression burden they experience, and then otherwise everyday discrimination such as racism, sexism, and homophobia. Due to a person's low socioeconomic status, they may have a neighborhood environment where it's unsafe to exercise or go outside. They may have poor health literacy, and then underlying distrust of the medical community in general. These all also feed into other areas of social risk, where someone may have food insecurity if they live in a food desert. Someone may have housing instability and otherwise a financial strain. Limited transportation is also a major issue, particularly for communities that live in extreme rural conditions, because they can hinder a person's ability to access medical care. So through intermediary determinants of health, both of these things really define a person's social position. A person's social position may lead to abnormal psychosocial and environmental stressors, which then lead to poor health choices and may lead to biological and psychological sequelae. All of this will eventually impact cardiovascular outcomes and someone's overall health equity. A special population that I want to note is Black and brown women, because they interface with several areas of social determinants of health, from lower educational attainment, which may limit their health literacy, to their physical environment, which may lead to a lack of housing stability, to their interface with the healthcare system in general, lack of health insurance, their identity and sexual orientation, their underlying social support, and experiences of systemic racism and sexism. Another way to think of this is a model where you have overall determinants of equity. A lot of these really will define a person or community's social context, and this may be abnormal because of things like racism, sexism, classism. These, again, define overall social determinants of health: someone's access to health care, their neighborhood that they live and work in, their access to healthy food, if they have housing instability, what sort of education they were able to attain, which defines their employment. Again, these issues, through intermediary determinants of health, define other biologic factors and behavioral factors, and may lead to substance use, sedentary lifestyle and lack of exercise, smoking or poor diet. These overall will then add to a person's biologic susceptibility to mortality and morbidity due to cardiovascular disease. Another way to think of this is the health tree model, popularized by the Health Resources in Action group. Their model is a tree, so there's underlying systems of the dominant culture, underlying systems that are really defined by structural racism. So this may be, again, racism, poverty, someone's social status, underlying sexism, xenophobia, ageism. And this really sets up a context in which a person grows and works. Some of these can be considered a person's underlying root cause of health, which then leads to other social determinants of health, such as low educational attainment, a person's occupation, housing and housing instability, a person's social environment, or what have you. Again, these define healthful behaviors. So persons under abnormal social determinants of health are more likely to participate in unhealthful behaviors, such as lack of exercise, smoking, substance use. These lead to a variety of abnormal health conditions and health inequities that are seen in these populations. So again, this entire context really leads to a lot of the health inequities that we see in Black and brown communities in this country. So I would be remiss if I didn't mention the Adverse Childhood Experiences study. This is a study that was published in 1998 through the Kaiser Group in California. And what they basically did was they measured several different areas of household stress, toxic stress, and parental dysfunction experienced by children. The researchers defined 10 areas of toxic stress experienced by children, and these were various forms of abuse, whether it was physical, sexual, or emotional abuse, various forms of neglect, seeing a parent use illicit substances, having parents that were separated. And basically the researchers came up with an ACE score, an Adverse Childhood Experiences score. So if the child before the age of 18 experienced just one event in any of these categories, not necessarily the number of experiences per category, but if a child experienced physical neglect, for example, they would get a point for that category. And what the researchers showed was that children with higher ACE scores had more adverse health outcomes as they grew. whether this was cardiovascular disease, obesity, increased prevalence of diabetes, increased prevalence of cancers and sexually transmitted infections. Higher ACE scores also led to abnormal or unhealthful behaviors such as smoking, alcohol, and drug use. Lastly, higher ACE scores were associated with lower socioeconomic status and poorer graduation rates and academic achievement.
I think it's important to remember that there's no one person behind the wheel driving the structural racism. It's something that is in our society, and we have to look for it because it's everywhere. An important study that we've done at Northwell has looked at structural racism and also the social determinants of health to figure out how they actually impact things like out-of-hospital sudden death. And so this is a study that we did, and this is in the first wave of the pandemic. And we knew in the hospital that people were dying at high rates, but we wanted to see outside of the hospital who was dying at high rates. So we contacted the emergency medical services and we asked them to give us the information about patients who were dying out of the hospital, non-penetrating trauma, and look at it in 2020 and compare it to a historical norm in 2019. And we wanted to see who was dying by zip codes. They gave us that information, and you can see on this map, it's a ratio of who's dying in 2020 to 2019 by zip codes. And if you look at this map, the blue colors are the ones that are closer to the 1, and the red colors are the highest we saw was 20. So there's a neighborhood where actually people are, in the first wave of the pandemic, people are dying maybe 1.5 times as much as they were last year. And then there's another neighborhood where they're dying 20 times as much. Look at that disparity and what's going on. And so we had, and knowing that 80% of health outcomes come from things other than the medical encounter, we actually looked at those social determinants of health and looking at structural racism to see what we would find. So we put it all into multivariable analysis, looking at education, race, and all of those things that we had by census data. And so we understood each neighborhood, what the race was, what the racial composition and demographics were, who was unemployed, who had medical insurance, what their educational attainment was. And we put that all in a multivariable analysis. And what we found was that Black race, the more that a particular neighborhood had a higher percentage of Black race, that accounted for some of the difference. And also was educational attainment. That also accounted for a huge difference. So if you didn't graduate from high school, the more that neighborhood had people who didn't graduate from high school, the more they were dying in those zip codes. So Black and also educational attainment. And I think just showing you the real impacts of structural racism, structural inequities, these actually translated to people dying disproportionately higher than other people in New York City. And what happens when you think about discrimination and the stress that causes? This is talking about discrimination, interpersonal, institutional, and structural, and health outcomes. And so there's looking at something called the Everyday Discrimination Scale. And we see that people who responded on this survey, and do you feel like people are less courteous of you? Do you feel like you're being discriminated against? Do you feel like people think that you're not smart, etc.? The higher you scored on that scale, the higher you had negative health outcomes. So coronary artery disease, hypertension, all of those things. And the people who scored highest on those scales in America were Black people. And then they also looked at that and correlated it with blood levels and other clinical factors. So they looked at things like C-reactive protein, which is inflammation, and saw that there was higher amount of coronary artery disease in people who felt discrimination. They looked at diastolic blood pressures and found that that also was increasing in people who felt discrimination. Coronary artery disease, as I mentioned, I think importantly, they found that cortisol levels are your stress hormone. And that is higher in people who feel more discrimination from structural inequity, structural racism. And guess what cortisol levels are related to? They're related to central adiposity. And that's what is a predisposing factor for diabetes. Also higher norepinephrine levels. So when I hear about Black and Hispanic patients, and especially in the United States, who have a disproportionately high amount of diabetes, hypertension, think about structural racism, discrimination, and how that interacts with social determinants of health, and they actually produce these negative health outcomes.
A salient example of how social determinants of health can lead to increased mortality and morbidity in a certain population is best seen in the cardiovascular status of the American Indian population in this country. So cardiovascular disease was once thought to be rare in American Indian populations, but due to abnormal social determinants of health, including systemic racism, we've seen a rise in cardiovascular disease in this special population, and now it's the number one killer in American Indians in both men and women. Dr. Barbara Howard published these data in Circulation in 1999, and what she documented was a twofold increase in the incidence of coronary heart disease in the Strong Heart study compared to the ERIC study, which was comprised mostly of Caucasians. So many American Indian communities have an exaggerated prevalence of traditional cardiovascular risk factors, including obesity and diabetes, when compared to the general population. And I will say that despite an elevated public awareness of cardiovascular disease in American Indian communities, the prevalence of obesity, diabetes, hypertension, and dyslipidemia is increasing. American Indians also have premature cardiovascular disease mortality and morbidity, and cardiovascular disease mortality rates 20% greater than all other U.S. races. Unfortunately, American Indians also die of cardiovascular disease at younger ages, and it's estimated that 36% will die before the age of 65, compared to 14.7% of non-Hispanic whites. The increased prevalence of diabetes in indigenous populations in this country really is the number one cause of heart disease that we see in these special communities. So attempting to obviate the effects of these health inequities and decrease disparities that we can measure in our clinics is a complex process. Really involves a multifaceted approach, from approaching a community's social, political, and economic context to engaging with a person's specific community to addressing a person's specific lived personal experience.
And looking at these particular health outcomes and just looking at race and life expectancy, it's clear that because of discrimination, structural racism, negative social determinants of health, that there's disparities that we see in terms of race and life expectancy, where you see that white women live the longest amount of time in our country and black men live the shortest amount of time. And again, I just want people to contextualize that it is race, stress, discrimination, and those negative social determinants of health and how they're impacted. I know we're talking about social determinants of health in this pathway. It's important to understand those negative social determinants of health and why they came about. And they are because of segregation in the United States of America and redlining, where people are not allowed to buy houses in certain neighborhoods. And we have it in this particular country that your neighborhood and your zip code really relate to where you go to school, how much money you can make when you're in the job market. And everything that we have is tied to where you live. And you hear about these things, that your zip code portends more to your life and your mortality than your genetic code. And this is all that we're talking about. And so looking at how redlining and Jim Crow and segregation really, as on a structural level, has put those negative social determinants of health, where you have poor housing, you have poorly funded schools, poor access to capital, and then put that together with the discrimination and the stress, you have toxic stress and all of those. That's how you get sort of poor health outcomes. So I think it's always important to look at it. And again, just understanding the two and how they're related. Structural racism, social determinants of health, and how that even triggers and cycles with implicit bias is important.
The most effective way to address some of these issues is to actually approach the communities themselves, to help them with their own needs assessment and come up with interventions which will be important to the community members, and their leaders. So this may be in the form of policy interventions such as improved access to health insurance or education, poverty interventions, and urban planning. It may be through community interventions with investment in community-based organizations and community health workers. There also can be individual interventions such as lifestyle coaching, parental classes, medication management, social determinants of health screening at primary care clinics, and other care coordination and collaboration. Successful multi-level interventions really make healthcare available and accessible to some of these communities, as well as affordable. Targeting these levels at both a social and political level, as well as a community level, will allow interventional interventions to be more impactful. In general, this will have a greater impact at attenuating health inequities seen in Black and brown communities in this country. It will decrease some of the measured health disparities that we see in our clinics and will lead to overall better health outcomes. And all of these will help to attenuate health inequities that we see in Black and brown communities, to decrease the health disparities that we see specifically within our patients, and to improve health outcomes for all under-resourced communities in the United States.
So thank you, and really look to the American College of Cardiology, Diversity and Inclusion, and Health Equity to find out more about structural racism and healthcare disparities.